All right, good afternoon, everyone, and welcome to the keynote address for the Developing Evidence-Based Drug Policy Conference, which is hosted here at the Rockefeller Institute of Government. My name is Patricia Strach, and I am a professor at the University at Albany and a fellow here at the Institute. And I'm going to be introducing our next featured panelists, which is Rob Kent and David Holtgrave. Following this keynote address, we have one more panel, which is Disparities in Substance Use Disorder Treatments, which will conclude the conference. So you can access that next panel on the conference's Eventbrite page or through the email you received with links to the panels. If you've missed a presentation from this morning, there were some great talks and you wanted to watch them, they'll be on the Rockefeller Institute webpage, which you can access selecting past webinars and events. And so without further ado, I want to introduce our keynote speakers. And I also want to say we have the opportunity for questions at the end. So feel free to type some questions into the Q&A and we'll get to that at the end of the speakers. And so first off, we have Rob Kent, who Senator Harkin said earlier was a great loss when he went to the federal government, but it is also a great gain for the other 49 states. He is the general counsel at the Office of National Drug Control Policy. Prior to that, he was the vice president of advocacy and general counsel for the American Association of Orthodontists. And probably many of you on this webinar know him from his work as the general counsel for the New York State Office of Addiction Services and Supports, OASIS. And at OASIS, not only did you see him at every forum across the state, he probably put thousands of miles on his vehicles, but he provided overall legal support, policy guidance, and direction to OASIS Executive Office and all divisions of the agency. He led the OASIS efforts to implement New York State's heroin and opioid task force recommendations, including the Combat Addiction and Heroin campaign. He also led efforts on the implementation of historic legislation to increase access to treatment, including harm reduction services. He has co-authored articles on patient confidentiality and sober homes, and he has presented nationally and throughout New York State on the addiction systems of care. And in addition to Rob, we have David Holtgrave, who is a detailee under the Interagency Personnel Act with the Office of National Drug Control Policy, Executive Office of the President, where he serves as a senior policy analyst. He's also a colleague of mine at the University of Albany, where he is a dean of the School of Public Health and a distinguished professor. And Dean Holtgrave has a 3-decade career in public health, including senior positions at the Center for Disease Control and Prevention at Emory University, at Johns Hopkins University, and he served on the Presidential Advisory Council on HIV/AIDS during President Obama's administration. And he has a number of highly cited rigorous research papers about important and timely health policy program and questions. He has worked on infectious disease, harm reduction, especially syringe exchange, and social and behavioral science, health equity, and translational science topics during his career. So I'm very excited to introduce these two great speakers, and I'll turn it over to Rob first.
Appreciate you inviting me. It's wonderful to be remote, but be in New York remotely. I was a New Yorker for the first over 59 years of my life. This is the first time I've lived outside of New York State. I'm coming to you live from DC, although I live in Virginia. But it is nice to stay connected. And I do have to say, I've been connected to Patty and the Rockefeller Institute folks for a number of years when I was at OASIS, and always appreciated their work, particularly Stories from Sullivan series and the research and real-time approach that Dr. Malakris used to beat into my head regularly. But it was incredibly helpful to me when I was in New York. And I think it's a model for the country. And I'm not going to steal too much thunder, but actually, so we've reorganized at ONDCP. So we're part of the White House, so everyone understands. We're part of the Executive Office of the President. ONDCP coordinates drug policy and drug funding throughout the executive branch of government, to make sure there's consistency and coordination to the extent that we are best able to do that. But the ONDCP office that I came into, we've reorganized. Actually, it happened October 4th was when it took effect. And two things we did that were of particular note is we recreated an Office of Public Health. Because I mean, we have obligations as it relates to supply reduction, but also with demand reduction. But also important and probably most relevant to this conversation, we did create an Office of Translational Research, and Dr. Holtgrave is helping us stand that up. And we're partnering with Dr. Holtgrave, a number of researchers, because research is critical. It's absolutely critical. And why do I say that? So we need to make policy decisions in the moment, because, you know, you look at what's going on, the landscape. So we released the latest CDC numbers yesterday. So the last 12-month period, ending in March of 2021, there's 99,000 predicted drug overdoses. And to break it down for those folks who are from New York State, the number is over 5,500. So that's about a 30% increase year to year. And it's been that trend consistently. I hate to say it, but I would expect eventually we'll reach over 100,000 as these numbers roll through the year. And it's just totally unacceptable on every level. And so that's the landscape we work in. And although I didn't start my job until mid-February, I was on a call where he swore in the first day, folks, my boss being one of them. And the president talked about, we just need to do our jobs, and we're up against it on so many levels, COVID and all that's created. And he said, I need you to do your work. I need you to get things done. You know, the American citizens need to know that their government can be responsive to what's going on and be helpful. And so we're focused on everything we do needs to be oriented towards reducing that number and starting to turn it into the opposite direction. And it's not only do we need to make policy decisions in the moment, and research is critical to that, we're making investments. The federal government, previous administration doubled the Substance Abuse Prevention Treatment Block Grant, or SAPT block grant, which is the primary source of federal funding for addiction services. That normally is about $1.8 billion. They doubled it at the end of 2019. So New York State in particular, they get $104 million. That's part of their regular annual block grant. They got another $100 million. That notice of award came out in March of this year. And then the President Biden's American Rescue Plan added almost another doubling. It was about $1.5 billion. So New York got another $90 million. In all the states got large sums of money. So we're putting money into the system, but it's critical that we look hard at everything we're doing, policy decisions we're making, funding decisions we're making, to make sure we're investing in things that work and not investing in things that don't work. And suffice it to say, you know, one of the things that I want to dispel right away, or at least from my perspective, and I am not a researcher, I'm a lawyer. So everyone wants to cite COVID as the reason we've had this, you know, huge spike in overdose deaths. And the data I look at says that contributed, but overdoses were going up before COVID-19 hit. And they were going up, in my opinion, primarily because the substance of illicit, illegal fentanyl that's the primary culprit. I mean, if you look at the overdose numbers I just cited to you, I think more than half of those overdoses, illegal fentanyl was part of the contributing factor to the overdose. So the drugs changed. You know, when we started this whatever we want to call it, this voyage, I don't know what we call it, but it you know, it really did start with prescribed opioids. We moved to heroin. It's pretty much fentanyl at this point. And to be clear, there's another thought out there that I think is partly true and partly not true. And it's that people don't know they're taking fentanyl. That's not entirely accurate. I talk to people, and Patty, by the way, the car I used at Oasis had 100,000 miles on a yearly basis. So it's a big state, as you all know. But I think people are seeking it out. And we have to know that. Like when you guys are doing research, to me, that's a relevant factor. And why are people seeking it out, right? So, we one thing I would say to you as well is that we are oriented to make changes. I mean, I'm proud already that, you know, we issued practice guidelines administratively to make it easier for prescribers to offer buprenorphine to individuals who need that for opioid use disorder. We continued the emergency relief that made it easier to get extended take-home doses of methadone and to prescribe buprenorphine through telehealth means. Those are two items right there that I mentioned. I mean, we believe they work, but it would be wonderful to have some research to tell us, you know, did they work as we did it? Because we're looking at obviously extending that relief. We have to. How can we not when we're losing almost 100,000 people a year? So, and then there's this other factor as well in terms of funding. There's the potential through the great work of Attorney General James and her staff through the opioid litigation settlements. The state could get another, you know, $1.5 billion over the next decade and a half to be invested in abating the nuisance of opioids and overdose. Same thing here. I mean, research would be important there to determine that funding is spent in the right way. And to me, it's research in terms of what's already going on, but also then examining what's done as we make these investments to make sure they work. And then if they don't, to move on. The Rockefeller work when I was at Oasis was incredibly helpful, but I have to tell you, so much of what we did was, and that's why I traveled all the time. It was gut. It was talking and listening. It was more listening than talking, but listening to people in communities tell us what was going on in their communities, and then trying to give them resources. And most importantly, I think from a government perspective, get the heck out of their way. Let them do the work. You know, and to me, that's fundamental as well. You've got to trust the people who you authorize to do this work, because if you can't, I don't know what hope we have. And I trust the providers, I still do, because I don't think you work in this system if you don't have reasons other than wanting to become hugely wealthy and buy a remote island at some point when you retire. That is not going to happen in this world. And if it does, you're probably going to hear from the Department of Justice at some point. So research is critical as well, because as far as I'm concerned, there is no more stigmatized medical condition than substance use disorder. And to be honest with you, so much of what we focus in on is trying to build rules or undo rules that are written from a, we don't trust the person who uses drugs. We don't trust the addict. I don't use that word myself. I say it for emphasis, but we don't trust the people who use drugs. And so we build rules, unlike we do in any other healthcare setting, that make it difficult for people to access care. And I will tell you, I still go to meetings, and there's still too many folks, including folks who I would otherwise consider to be very intelligent individuals, who still believe SUD is a failure of will. It's a personal failing. And these are people in really influential, powerful positions. And so that's part of what we're up against. And so research is critical because it's our antidote against this nonsense, this stupidity. The data and the research will help us make good decisions and help us fight stigma with the facts. And you know, as I said, we need it. And we have to be willing, by the way, to let you do your work and take what you tell us. And sometimes that might mean something we just believed in with all the core of our being is the right way to go. It wasn't. You have to be willing to stop doing things that you thought intellectually was the absolute right thing to do, but it didn't work. And so, you know, research across the board is going to help us make policy decisions. It's going to help us make funding decisions, and it's going to help us fight folks who make policy decisions who on some level believe that addiction is still a personal failing, a lack of willpower. And I'm going to tick off some things that I think are areas that I would love to see research in. And Dr. Holtgrave is going to talk, you know, far better than I can to this audience about ways research can assist us in moving forward, and why we think it's important at the federal level and why we created the Office of Translational Research. And let's start with a few simple things. What makes people access treatment? Why do people go to treatment? What makes them stay? What makes them not go to treatment? And then if they don't go, why don't they go? And then, you know, that kind of information, I will tell you, I use the work to rewrite the rules in OASIS in New York as it related to outpatient treatment. I'll give you one perfect example. And I blame Twitter for this, but I was reading Twitter on a weekend and there was a whole, I don't even know what you call it, a feed, I don't know what it is, but it was a lot of folks talking about the fact that treatment programs having abstinence as the goal of treatment leads people to not go to treatment. It leads people to leave treatment, to get kicked out of treatment. And with the drugs on the street at this point, people die because of that. And so I pulled up our rules. I said, there's no way abstinence is the goal of treatment. And sure enough, I pulled up our outpatient regulation. I did a word search for abstinence and it came up and it said abstinence is the goal of treatment for an OASIS outpatient clinic. So that started my odyssey of, well, that was the first markup of our rule. My staff thanked me so much that I sent them at like 5 o'clock on a Sunday afternoon, my first set of edits to our outpatient rules. But that's exactly it. That got in the way of people accessing care. And what's changed with the drugs now versus maybe years ago where abstinence was the goal of treatment, when people would get kicked out because they continued to use, they weren't going to go use substances that would kill them. Now they will. I mean, you know, so we have to be mindful that the decisions we make now are life or death. And we have to, you know, I don't love buzzwords. I hear them all the time, but people talk about evidence-based treatment. I wrote the rule or rewrote the rule from a perspective, what is not evidence-based? Like, for instance, mandating people get counseling in order to access medications they might need to treat their addiction. Kicking them out for rule, like they got caught with a cigarette, whatever it might be. Kicking them out because they continue to use other substances, not allowing them to continue to get access to the medication if they refused to get to buy into counseling. By the way, I don't know of any other health condition where we do things like that. When people don't comply with treatment, in most other health conditions, we wrap our arms around them tighter. We bring them in. What can we do to keep you alive and get you healthier? We need to do that in this space, and we need research to help reaffirm that that's what we need to do. So, and I'm going to tick off a bunch of other things. We need to redefine what success is, and what is it for other conditions. It mystifies me that we like define success like they don't get rearrested or they don't use again. That's like saying the diabetic's never going to eat something they should have eaten. you know, that the person with heart disease shouldn't have had that 40-ounce T-bone steak last week. It just, we don't do that in any other circumstance, but we've allowed success to be, for a chronic medical condition to be, you know, success means they don't need treatment again. They're probably gonna need treatment the rest of their lives. It's how intense the treatment, but the notion that they only succeed when they're not in treatment is not working, because that's where we're at now, and 99,000 people lost their lives last year. So we need to understand that. Criminalization of drug use and possession, and all these deflection programs, as they're being labeled, you know, pre-arrest diversion, drug courts, you name it. There's plenty of programs out there that are doing this kind of work, and it would be great to get some research. And by the way, I offer this as a public service announcement. Any researchers interested in connecting with people that are doing any of the stuff I talk about, I will connect you, because I know people who are doing it. And why is the deflection programs for criminal justice settings important? Because they don't listen to people like me in the criminal justice world. Law enforcement doesn't want a lawyer from a drug policy agency telling them how to run a jail or a prison. So, and I learned this when I was in New York, when I was trying to convince sheriffs to allow medication for opioid use disorder in their jails. And they'd listen to me, they'd humor me, because I was a supposed big muckety-muck at a state agency. And they were humoring me, figured it out. So what I started to do was invite sheriffs who were doing it. Could you reach out to your colleague and tell them what it's meant for your jail, that your guards actually feel safer guarding the inmates because their medical needs are actually being attended to. People don't come back whose primary issue is drug use. And so some research on deflection programs. There's a great program run by the Staten Island District Attorney that he's taken to a whole different level. But at its beginnings, it was about diverting people pre-process of arrest for, you know, minor drug offenses or minor crimes related to drug use and drug possession. And it's working. But I can take all the stats he produces, but it would sure be a heck of a lot nicer if there was a peer-reviewed research project and paper that looked at it and said that it's absolutely verified this works, or it doesn't. I mean, we have to accept whatever it might be. The impact of the COVID-19 emergency relief. I mentioned the two key pieces we did is we extended the ability for programs to offer take-home doses of methadone in the opioid treatment programs. There's a whole bunch of work we need to do on that, and David and we at ONDCP are doing some of that work in terms of the methadone rules. But did programs use it? Did programs have any more significant adverse events because they may have given people more doses of methadone to take at their home versus coming into a clinic every day? Telephonic buprenorphine. And actually she's doing research, but Justine Waldman, who runs Reach Medical in Ithaca, New York, is basically servicing, I think she's over 5,000 at this point, buprenorphine patients, most of them telephonically. She created telephonic bupe initiation in Plattsburgh from Ithaca, New York. But I know she's doing research already, but I know there's other folks doing this work. Is it working? As we're trying to argue to extend these rules beyond whatever we're defining as emergency, it would certainly be helpful to have research that validates that it worked. There were no more, or maybe even there were less adverse events when we opened the doors and made it easier for people to access care. We need more research on cannabis and marijuana. You know, everyone thinks they figured it out. We should legalize and medical marijuana and synthetic products, but we don't really know enough about the effects of the substances. And as I say that, I think we need more research on the synthetic illicit fentanyl that's being seized. And by the way, just plug for ONDCP, we've put forward a proposal to Congress to make it easier for researchers to research all Schedule I controlled substances, because that we need to do that. If we really want to understand the effects of these substances, we've got to have true research done by people who do true research. So plug for that. Bills in front of Congress, weighing in as a researcher, go right ahead. But, you know, and then ultimately, a few more things I want to add. We need to research harm reduction. And when I say harm reduction, so I want to be really clear, I'm talking about access to naloxone and syringe service programs. And because understand that while New York has a long history, almost 3 decades, if not over 3 decades history of syringe service programs and how they work and how effective they are. And there's a huge evidence base out there. We're still fighting around the country. There are states and localities that are shutting syringe service programs down in the middle of what we're in the middle of with the numbers I just cited for you. So, and let me tell you one of the examples. So access to naloxone. One of the questions I hear, believe it or not, is does it enable drug use? I think that it kills me that we have to answer those kinds of questions, but I really think we need to. Syringe service programs, do they encourage drug use? You know, we know what they do. I mean, you know, the best example is Indiana. The health commissioner years ago had a huge outbreak of Hep C, HIV because of intravenous drug use. The health commissioner at the time, Jerome Adams, may have heard of him. He had a future after that. So he asked his governor at the time, Mike Pence, to authorize syringe service programs. They did it on a 30-day emergency basis every 30 days. It eliminated the outbreak because the outbreak was connected to intravenous drug use and people sharing needles. So it works. And it works from a health perspective as well. We know that, but we got to keep beating that drum, because I will tell you from our own perspective, if harm reduction is not normalized and expanded in this country, we will not make the impact we need to on those overdose numbers. So we need that. Access to methadone generally, and then jails and prisons in particular. There's plenty of jails and prisons now doing the work. Like I said, I can connect you. And then, you know, I'll put a pitch for Kelly Rowe, who runs Second Chance Opportunities in Albany. It's a recovery center, but she's got a recovery center, an employment program, and housing all connected. And she's actually trying to get research done to study her model to see if, you know, to validate it, if it can be validated, and to maybe use it to create the model in other parts of New York State and even in the country. So, and I'll end with this. I think whatever we do as well, we're very much focused, because the president has made it clear it's a priority for him. We need to be looking at everything from an equity perspective. We need to understand the impact of policies and rules and programs and service locations on Black and Brown communities, and the impact in particular, we know for a fact on criminal justice issues. You know, we criminalize drug use and drug possession. There's no doubt about it. And that significantly impacts Black and Brown communities. And we need to look at that. We need to understand it, and we need to fix it. So I could go on, but then I would eat up Dr. Holtgrave's time, and I don't intend to do that. So bottom line is, your work is critical. We need your help. As I said, you want places to go research, Patty can get you my contact info. I'd be happy to connect you. So with that, I will stop talking and I'll turn it over to my esteemed colleague, Dr. David Holtgrave.
Thank you so much, Rob. It's an honor and a pleasure to be on the panel with you and co-present today, and to be on the panel with Professor Strach as well, and to be part of this really important conference on drug policy at the Rockefeller Institute. So thank you for having me to be part of the discussion. I thought I would dive in a little bit further on the theme that Rob so rightly brought up about the importance of research, and talk a little bit more about translational research. As Professor Strach brought up earlier, my usual hat that I wear is as Dean of the School of Public Health here at UAlbany. but also now I'm detailed a few hours a week working with the Office of National Drug Control Policy on translational research. And as Rob rightly mentioned, with this recent reorganization at ONDCP, there's now a whole standalone office of translational research. And for somebody that's been doing translational research for as long as I have, I'm very excited to see that there's actually a part of that important office of ONDCP devoted to this key area of translational research. So what's the mission of OTR? I think it really can be summarized by saying its purpose is to develop, to implement, and to evaluate evidence-based drug control policy in the US. And has been noted since it started on October 4th when the reorganization was rolled out. In these first 10 days, I'm not going to unveil the results of some major new study here, but I thought I would talk a little bit about sort of the goals and the philosophy of thinking about translational research in this space at ONDCP. So what do we mean by translational research in general? I thought I'd spend a moment there. And also to say that the lens kind of that I bring to translational research, I worked for several years in the 90s and very early 2000s at CDC, and I've been doing HIV prevention work for about 30 years. And part of that time at CDC was to serve as the division director for the Division of HIV Prevention, Intervention, Research, and Support. And we had 5 branches, a branch that delivered HIV prevention programs and community-based organizations and health departments throughout the country, a branch that focused on applied research, another that focused on program evaluation, a 4th on capacity building, and a 5th on communication. So really our job in that division at CDC was how do we get the program to move closer to the science and the science to move closer to the program? And very much as you've already heard in this session and I believe throughout the conference, it wasn't unidimensional. It wasn't, we've got some finding and now we're going to go and make sure that that gets implemented in the field. But it started with really listening to the providers, listening to people who were doing HIV work or substance use prevention or treatment work or other areas, taking those realities in and defining a research agenda that would be responsive to answer the questions that mattered in the field and also to answer them in a time frame that was useful as well too, because as we know, these decision-making windows at a community-based organization or for the federal government or a state, those decisions have to be made in a certain time frame. You can't say, I'll get back to you in 3 years or 5 years and let you know. You need to move in real time. And so again, that experience with CDC was kind of how I thought about how program and data relate to each other. And how do we do capacity building as well too? Because if we want to make sure that we've got organizations that can deliver evidence-based programs, how do we make sure that they have the resources, the training, the staffing that's necessary to do that kind of implementation? Also, I think in this area of translational research, there's a lot of terms that sort of get thrown around. I think translational research is one term and tends in the substance use field to be talked a little bit more about as we've got a new treatment or we've got a new scientific finding, maybe about the biology of addiction and how do we move that finding into the field. I think we're hearing now terms that are maybe include that important direction, but also are a little more bi-directional, terms like dissemination and implementation research, which is really what NIH and the Fogarty programs tend to use, or implementation science more broadly, which really thinks about how do we get program and science talking to each other, and even a newer field called knowledge brokering. And in knowledge brokering, we think about people serving as active facilitators to try and bring researchers and bring service providers and policymakers together in the same space. So I think that's kind of the newest area. And I really think this theme of making sure that when we talk about translational work, it's not just a unidirectional arrow from I published something in a journal, now I want everybody in the world to do what it says in this article, but how do we get this dialogue to go that it's a bidirectional evolution and a bidirectional dialogue over time? Also, I think that there are aspects of translational work or implementation work that need to be informed by a number of factors. And there's this great tool called the Hexagon tool from the UNC National Implementation Research Network. And this particular one was developed by Kaiser, Zabel, Zajic, Smith, and others in 2007, and it's been updated a few times since. And they really talk about this issue of whenever you're going to implement a program in the field, there's at least 6 different things to keep in mind. Sure, the evidence base is one. Do we have some reason to believe that this will work? But you also need to know what's the need. And very much as Rob said earlier, are you starting by listening? Are you starting to make sure that there's a real need that you're trying to address? Second, the notion of fit. Are you making sure that you've got an intervention that's going to work well and it's something that the community may be interested in? Another area is resources and supports. And I think this also gets to the issue of scale in a way too. Sometimes we think we've got a new intervention. It would be great to deliver in public health space, but we've only got the resources to address the needs of 1,000 people when in fact 1 million people or more people need to receive that service. And so getting the scale right, getting the supports right. Also, I think the 5th area in this Hexagon tool from UNC focuses on readiness and usability. Is the intervention one that's kind of ready for prime time? When I think of syringe exchange programs, we did work on syringe exchange when I was at CDC in the 90s. But even before that, harm reduction at one time in the early 90s meant providing people with water and bleach that they could use to try and disinfect works as much as possible. And so there's been this real evolution over time of what did we mean by harm reduction? What were the tools and were those ready to be used? And then last, capacity, and just making sure, again, that the persons who are providing this service have the necessary staff that are available, the necessary training, all the kinds of capacity building efforts that are key. So when I think about implementation, I think of at least these 6 kinds of factors and many more that we could discuss as well. But it's not just about, here's my article, let's go do this in the field, but how do we address, and we can study all of these factors. Also, I think the point that Rob made earlier was so critical, is that when we think about these factors, making sure that we remind ourselves that they all occur in the framework of social determinants of health. I know in the HIV space for us, food insecurity, housing, so many of the social determinants make such a difference. And one line of work that we did a few years ago looked at some predictors like social capital, poverty, and income inequality as predictors of a number of public health challenges. And what was interesting was always the biggest predictor was social capital and income inequality as opposed to poverty in and of itself. Poverty was important, but it was the social injustice, the income inequality, that was even a better predictor of some public health challenges. So I think keeping these social determinants in mind is key. And also this lens of health equity is also really critical in thinking about how can we develop goals at the national level, at the state level, and at local levels to make sure that we're really achieving health equity. Sometimes we think about proportionate reductions, but at the end of a proportionate reduction of some public health challenge, the health disparity may still be there. If we're going to really build health equity, we have to make sure we're achieving critical outcomes for all communities. And so let me just name a couple of more examples to illustrate what I mean by some of these concepts, and then a couple of examples of how we might be able to do some work in this space at the Office of Translational Research at ONDCP, and then I'll stop. I think a couple of examples is we can look at some of these translational factors and make them the subject of study themselves. So in the mid-90s, I did some work with Jeff Kelly, and we looked at whether you could take HIV prevention interventions for gay men and for women of color at particular risk for HIV, and and these were interventions that had NIH funding, solid evidence base. And if you wanted to help translate them to community-based organizations, the real question in that study was it enough to provide documents, or did you need training workshops, or did you also need a hotline where people could problem solve about the actual implementation over time? And not surprisingly, you needed all of those things. They were all important. It's not just enough if you want to translate science into programs to say, here's the documents, but you need those kinds of capacity building efforts and ongoing problem solving as well. Second area was I worked with Nazreen Jazani, who was first a doctoral student and then a faculty member at Johns Hopkins. And she was really interested in her dissertation and later of how do you empirically study whether academic researchers are actually working with program managers and policymakers at the local, state, federal, and global level. And if you interview those policymakers, will they say that that work from the research sector was useful and influential? So we've got a number of empirical papers that really try and examine that relationship as the area of inquiry. Third, I will just mention that I think when we're talking about translational work, it's important to think about that we can intervene at the individual level, but also sometimes at the healthcare service delivery level. And some work that I did with Kriti Jain, Kathy Malsby, AIDS United, and other partners really looked at in a number of cities in the US. If you looked at the healthcare service delivery system for HIV, how fragmented was it? What could you do to make it less fragmented? And if you did those interventions over several months, could you show evidence that the social network of service providers was different at the end of it? And we could actually show in Louisiana and a number of other areas that after you had concerted efforts to better coordinate service delivery, you could show a difference over time. And then my last example is just some work with Monica Ruiz at George Washington and others, looking at syringe exchange impact in Baltimore and Philadelphia. And I think such an important tool, and there's a lot of studies like this at Rockefeller and where you do interrupted time series analysis to see if I change a policy, if I change local regulations about syringe exchange, what do you get in terms of different outcomes? And our outcome we were looking at was HIV prevention as an outcome, but many others that you could look at as well. So just a few illustrative examples of these concepts. And then I'll just sort of close by saying, you know, I think at the Office of Translational Research at ONDCP, some examples of how this work could be done is, for instance, starting by looking at the administration's statement of national drug control priorities from this year and the eventual national drug control strategy that'll be out next year, and trying to determine what elements are most needed to inform the setting of goals, the establishment of metrics, and program evaluation strategies, all with an eye to both improve population health in the substance use space and build health equity over time. Second, I think one other example is that there's real interest in using mathematical modeling techniques or policy modeling techniques to implement, to estimate rather the potential impact of future policies before they're implemented. So you try and get some rough estimate of the magnitude of unmet need and the impact of reaching certain levels of service delivery needs, both on the health outcome side, but also on the economic side as well. Third, I think another area that will be useful for this new group is to conduct and facilitate state-of-the-art reviews of the science and programmatic reality in a number of areas of substance use inquiry. And just one example of this is we're partnering with the National Academy of Science, Engineering, and Medicine on an upcoming workshop that'll be in the spring of 2022 on methadone modernization. So that's coming up in the relative near term. And then final area is just utilizing data systems, whether they're quantitative or qualitative, to get early indications of emerging new threats, such as the new substances that Rob was mentioning earlier, fentanyl and others. And I'll close simply by saying, I'd like to issue everyone who's on the conference Zoom today to please reach out to me if you have thoughts about using translational research, implementation science research to inform substance use policy in the US. We'd love to get your thoughts, your ideas. This is literally a 10-day-old enterprise, so we're eager to hear your thoughts, get your input. Since my ONDCP email is longer and more complicated, I'll just say at UAlbany, I'm dholtgrave@albany.edu. Please reach out, write to me with any thoughts that you have. And I think we've got just a few minutes left for a question or a comment or two, and I'll turn it back to Patricia then.
Thank you so much. So we have about just a couple of minutes. So if you have a question, pop it in the Q&A quickly. And I'm going to take the opportunity, since I have you both on the line and I'm here too, to ask you, we heard this morning from a researcher, Nabarun Dasgupta down in North Carolina, who said that he is moving away from talking about evidence-based policy or evidence-based research to talk more about evidence-making interventions, right? With an acknowledgement, a lot of times we do great research, but it doesn't translate into the real world because we have these ideal kind of experimental conditions, and the real world is much messier. And so I wondered if you had thoughts about this, you know, a de-emphasis on this perfectly fundable research design and more of an emphasis on maybe less elegant research designs that have quicker results and that are more realistic to the situation in communities across the country.
You want to start or shall I? Either way.
No, you'll correct everything I say. but no, what I would say, right. I mentioned evidence-based treatment. Now, my perspective, based on a lot of on-the-ground interaction with providers, the research and the thoughts on fidelity to particular types of treatment, it doesn't translate to what goes on in a program. And it especially doesn't translate with the substances people are using right now. They are just wickedly effective. And so, and one of my colleagues, you know, has sort of flipped it around from a how we do policy work perspective. And it would be great, I think, for research to also, I think if we're going to constantly say a model used to fidelity works, I don't know that you're going to be able to do research because that validates, because I don't believe, except in maybe limited settings, that anything's being done with the fidelity that, and I'm not attacking evidence-based treatment, I'll be really clear, the modalities work, right? But do they work in the moment? And more importantly, you know, like I said, we're doing stuff in the moment. So I'm heartened to hear the comment that you mentioned, Patty, because I really think, like, I call it relevant research. It's stuff I need now to go make decisions as best as we can. You know, when I was at Oasis, my approach was, we're going to throw everything at this because we don't know enough about everything we want to do. We think they'll work, but we'll watch them as we're doing them. And if they don't work, we'll either, do we modify or is it not fixable? And you move on to something else. So that's a non-researcher lawyer perspective on your question.
No, it's a great question, and you know, and I agree. I think the idea of evidence-making interventions is really a great way to frame this, and made me think back kind of my time at CDC. So some of the things that we would work on in the division would start with maybe there was an intervention that came from behavioral or social science theory. It was developed, it was tested, and seemed relevant potentially to the field. We also funded projects, though, where someone in the field had a novel idea. They just said, this is based on what I'm seeing in the field. No study had been done yet. And we would work with our applied researchers and our program evaluation team to evaluate that and see, could we collect some evidence to show that not only was this an interesting and novel idea, But if you rigorously evaluate it, you could actually show that it was making a difference as well too. So I think that was key. And then also, you know, I'm a big fan of mixed methods of work where we're kind of blending quantitative, qualitative, and bringing them together in a truly mixed method study. And also worked in the late 90s a lot on the Minority AIDS Initiative while I was at CDC. And one of the things was, this was kind of circa 1998 or so, we were seeing such a big impact in African-American and Latinx communities of HIV. And it was, the epi data was very clear. And then the question was, how do we inform the programs and the interventions? And so one of the first things that was done was rapid ethnographic work, where people really went and did outstanding, very fast turnaround ethnographic work to really make sure we were going to be delivering interventions that were addressing the right social determinants of health. So I give those examples all to resonate with this great framing of evidence-making interventions. I think that's terrific. And those are just a couple of examples that made me think of as well.
They're going to storm my door to wrap this up any minute, but I did want to get one more thing in while I could. How we heard so many great papers this morning answering a lot of the questions or addressing a lot of the questions that Rob, you laid out. How do we get those into policymakers' hands? I mean, nobody has time, or your hands, nobody has time to sit there and necessarily watch all the videos again. Is there some kind of summary fashion for not just this conference, but for people in general to, you know, get you what you need and give you a link to find out more information on the kind of research that's been done?
We can get them to either of us or both of us. I mean, you know, like I said, clearly, you know, the team I'm working with, this administration values the you know, the impact of research, and we know there's research going on. So getting it to us, I mean, we're pushing. That's the stuff I talked about. It's not like we're sitting back and waiting for research to come our way. We're going to do our advocacy work because that's what we are. But getting it to David for him to share with leadership here and throughout the White House, I think is critical.
I agree. I think it would be great. And, you know, I would be delighted to share it with the Office of Translational Research team. And, you know, thinking about the topics that have been addressed and will be addressed through the rest of this conference with some of the policy questions that are coming up and linking together. So I'd be delighted to be part of that. And it would be a great example of knowledge brokering that we were talking about earlier. So that would be great. Thank you.
Well, you can expect emails from me. I want to thank you both. Thank you, Rob. Thank you, David, for spending the afternoon with us and giving us lots of helpful advice on what kind of research we should be doing too. I think everybody who's on this Zoom wants to make a difference in helping us figure out what that difference is.
Thanks for having me.
Thank you very much.